for such an important. Advocacy is, as Pia mentioned, is one of the staples of the work that MSDC does, and it's how we get our voices heard and make the changes that we need for our profession and for our patients. So I'm happy to be here. Please let us know if you have any questions. Use the chat function or email us offline if you think of something afterward. As Pia mentioned, this will be recorded and posted online, and the slides will be available as well. And also, as Pia mentioned, I'm very fortunate to have Dr. Meghan Schott with me tonight, and you'll hear a lot more from her in a few slides worth, and I will kind of bring her in just a little bit, and she can introduce herself then as well. But as Pia mentioned, I'm Klint Peebles. I'm a dermatologist in DC and suburban Maryland with Kaiser and the MSDC Advocacy Committee Chair for this year. But the purpose of this event, as you can see here, is Physician Advocacy 101. So we're going to talk about several important issues. The outline for this evening is going to be, first, I'll just mention a little bit about our prior successes and wins, and then we'll talk a little bit more substantively about what the DC Council is and how it works, how it functions, and some Advocacy 101 tips, and then the important critical issues on the docket for this year, and in particular for the upcoming hearing next Monday that we'll dive in and talk a lot more about soon, and then a time for open discussion at the very end. So MSDC has some key advocacy priorities as part of our mission to make the district the best place to practice medicine. And these follow four major themes. One would be providing quality care to all, protecting all physician practices, promoting public health, and making prescriptions affordable. And some of the topics we're going to be talking about tonight coming up for the hearings and beyond are going to dovetail very nicely with those key priorities. And these were launched within the last year or two, and they're kind of the guideposts in terms of the advocacy priorities for the organization at this point. And we hope to be making inroads on all of these. And so a few advocacy wins before we get started with the current issues, just to kind of go over a few of these. And we've talked about this in past advocacy meetings as well as some online webinars. But some of the wins recently would be regional reciprocity would be the first. So the DC Board of Medicine voted that Maryland and Virginia physician licensing requirements are substantially equivalent to the districts. And that's moving along nicely, just waiting on updates on that. But also with temporary licensure, things like flavored tobacco bans, midwifery regulation, scope of practice issues as well. And then, of course, the ever-present DC budget priorities in terms of physician loan repayment funding and postpartum coverage funding that have been included in the DC budget, which were priorities for MSDC. So all of these things are, and many more, are really products of the advocacy work that MSDC does. And that's thanks to all of our physician volunteers and the wonderful staff, including Pia and Robert, that really makes the wheels on the organization turn. So obviously very thankful for them. So a little bit more about the DC Council before we start talking about advocacy and how all of this works, right? So what is the DC Council? Well, so it's the governing body of the district, and their responsibilities include approving the government's annual budget, oversight of agencies, commissions, boards, and other entities of the district government. And the DC Council's work is basically conducted through a series of standing committees that we'll talk more about, that perform legislative research. They draft bills, review the budgets, do program and policy analysis, and of course, constituent services for all of us as well. It's composed of 13 members. There is a representative from each of the district's 8 wards, as well as 5 additional members elected in an at-large capacity, and that would include the chairperson of the council. And the members of the council are listed here, so you can see all 13 of them. Of course, it includes all of the council members for each of the 8 wards, plus the 5 at-large members that I mentioned. Currently, Phil Mendelson on the top left is the chair of the committee of the whole, and you can see all the other members there as well. So just to get an inkling or a feel for who your elected council member is, and the at-large members as well, and we'll talk about why those are important. So in terms of knowing who your council member is, well, you could reference that prior slide to see who they are, but you can also go to the website listed here, www.dccouncil.us. And it's a little bit deceiving in terms of how that looks when you go to that page, but if you go to the very bottom of that page and enter your address, it will actually pull up your council member. And you can contact your ward specific member as well as any of the at-large members for any issue that you're concerned about. And the general phone number for the council is there, and it will direct you to the respective council member's office, and you can talk to the staffers, leave a message, however you would like to do that. In terms of getting in touch with your council member, of course, you can email them as well. And constant contact is obviously really important so that they know the issues that are important to us. Now, as I mentioned, the DC Council does its work through a series of committees, and you can see all of these committees listed there on the left. Obviously, one that's more important to us in general would be the Committee on Health, although some of the issues we care about can make appearances in different and some of the other committees as well. But the Committee on Health is one of the more important ones for us. And on the bottom right, you can see who is on that committee. So Vincent Gray in Ward 7 is the chair of that committee for now. Phil Mendelson, as chair of the council, is on all committees, including that one. And there are representatives from Wards 1, 6, and 3 on this committee, as well as Christina Henderson, who is the at-large committee member or council member that serves on this committee. And so in terms of how the council's organized, this is kind of a busy slide, but it goes over kind of that organizational chart, so to speak, of how the council functions. When you see, first of all, the entire council here, the committee of the whole right under that, and then all of the different committees that fall underneath the committee of the whole. And so all of these committees do the work of the council, kind of providing information and insight on all of the issues that come before it, drafting bills, having hearings, and then all of that gets reported up the chain to the point where it's voted on by the council as a whole, and at some point intended to become district law. So when we think about advocacy priorities, I just wanted to talk a little bit about how to approach some of these issues that we care about as a medical profession. And I'll turn it over to Dr. Schott in a minute to get her thoughts and perspective on this. But it may be that, different folks listening to this may come from different places in terms of advocacy experience. And maybe you have no advocacy experience whatsoever. Maybe you do have advocacy experience, but it's been in another jurisdiction or in another state. And all the states work a little bit differently in terms of how their medical societies are run, and in terms of how their local and regional and state governments are run, and how we interact with the legislative and political system. And so DC is one that, as we mentioned, it has the council that we interact with, but the advocacy kind of strategies are really similar. And really, in a nutshell, the council has to hear from us. It's their job to listen. That's why they're there. And if they don't hear from us, then they have no idea what our perspective is. And our perspective, therefore, cannot shape what they do and the actions that they take. So on any given issue, lay politicians probably don't understand the impact that the issues we care about will have, not only on them, but on the residents and constituents of the district as a whole. And so it's up to us to really break down why these issues are important, how they affect someone on a day-to-day basis, what the impact is on the district's families. And we have to provide that context in terms of what these various policies and decisions and legislative items mean for our patients and for the health of the district as a whole. And the response often needs to be overwhelming to pass bills, right? Not necessarily so, but there needs to be quite a loud voice in many cases to really get things across the finish line. So when we interact with the council members, it's important to keep a few things in mind. Number one, it's important to be personable, approachable, and most importantly, arguably, would be honest, of course, respectful and polite. Brevity is really essential. Being concise and getting your point across in as few words and as succinctly as possible is going to be really helpful. These council members are hearing so many things from so many different people, from so many different pockets of the world, and different professions and different stakeholders, that it's obviously understandable that they could get overwhelmed. And so in order to have our message delivered in a way that makes a huge impact and sticks with them, it needs to be brief and concise and high impact. And from the physician perspective, obviously, we live in a profession that is highly evidence-based, science-based. We speak in technical terms and medical jargon. But in this capacity, it's important to really drill it down to easily understandable terms and to break down our practice of medicine into something easily digestible by someone outside of medicine. And part of the way that we do that is by emphasizing the patient story and how this has a real world impact on our patients every day, and how it impacts the care that we can provide on a day-to-day basis, and how some things just frankly impact our ability to be the best doctors that we can be. So definitely framing these situations with a patient context, with a patient story that really resonated with you and that would really capture the attention and capture the interest of the council members, because that's what's going to stick with them. Our data may not matter quite, even though it's important, it may not matter quite as much as how an issue such as, let's say, prior authorization or copay accumulators that we're about to talk about may impact a patient and their ability to get care, or may completely turn over their world in terms of their ability to afford medications and to have good outcomes. And that's really what this is about at the end of the day. And so with that, before we move on to specific issues in terms of our high priority concerns for the upcoming session, I wanted to thank Dr. Meghan Schott for being on tonight's webinar. And I just wanted to get her thoughts as far as general advocacy concerns.
Yeah, so I'm Dr. Meghan Schott. I'm a child and adolescent psychiatrist who also does a lot of work in the opioid epidemic, I guess. And you know, one of the important things about advocacy is like we've all already done it. And whether you're like fighting for your patient to get their drug actually approved from a prior authorization, or is it like if you're a pediatrician fighting for an IEP, an individual education plan. We advocate for our patients on a daily basis. So actually advocating in a more formal way is something that should not be daunting, because you're already doing it and you already have all this expert knowledge, more than almost anyone else out there. One of the things that Klint said is actually very, very important is emotions sell way better than facts. So if you are actually going and trying to be like the doctor and like spouting on the facts, no one's going to listen. And oftentimes they actually already have briefs about all the facts you're going to talk about anyway. But it's the stories that actually make an impact and actually make you want to change what you actually are believing and everything else. So I think it's really important to like kind of think about how you can bring a person alive in front of someone else. And sometimes a lot of what you do from an advocacy perspective is not in the form of formalized bills, which Clint's about to talk about. Sometimes just you talking to an audience, you don't know who's in the audience. One of the things that I did here in DC was actually just talking about the boarding crisis that's going on in psychiatric patients. And it was happened to be in front of a lot of lawmakers. And consequently, because the timing was right and everything else, they actually ended up passing a white paper, which actually went into law about how they are now sending mental health people with police officers from 9 to 5. So sometimes even your own words without actually creating that can actually change and create policy. And sometimes not even knowing what, not even just advocating for what your specific needs are can indirectly cause a whole avalanche and change of things. So be passionate. Your passion is going to show through it. And if you don't know, be honest about it, and then follow up and get back to them and say, hey, I don't remember this. Let me go look this up for you, and then bring it back. And that's going to really create a lasting impact. And maybe your whatever you want doesn't happen at that junction, doesn't happen right then and there, but like you're creating these connections that are going to actually create change down the line. And that's almost as important, because now they know you're the expert in this. They're going to look for you for other things to actually ask about and to understand what's going on. And that's a really big point of advocacy. It's not fast, it's very slow, but it can create change in the long term.
Yeah, thank you so much, Megan. And those are such important points. And just to echo something that you had said, we are the experts in a lot of this material and this content, right? And I think that the council members recognize that, and they want to hear from us. So definitely don't be afraid to make your voice heard, because you are recognized as the expert, and that's exactly the information they need to inform the decisions that they make. And just remember, they're going to be making a decision no matter what, whether they hear from us or not. So might as well throw our insight in to influence that decision, because it's coming whether or not we like it or not. And just as she said, so important to frame that in that personal way, and to bring some emotion into it and bring that passion into it, because that's what's going to resonate, that's what's going to be memorable. And I think that sometimes one of the barriers to advocacy for physicians is that we don't necessarily think that way. I think that some of us are a little bit more in tune to that narrative way of talking about things than others. But just as Megan said, we do this in one way or another every day. I mean, I would argue that part of the practice of medicine every time we see a patient is advocating for them. And this is yet another way of doing exactly that, just in maybe a little bit more of a formal capacity. So just to move on to some of the bills we're talking about. So these are two critical issues that have been designated as highest priority for MSDC. The first one is Bill 24-557. This is the Copay Accumulator Amendment Act of 2021. This bill is on the agenda for a public hearing on June 27th, which is this coming Monday, and MSDC will be testifying during that hearing. And we'll talk a little bit more specifically about that in a little bit. The next one would be 24-655, which is the Prior Authorization Reform Amendment Act of 2022. And I don't think I need to tell anyone here how important prior authorization is. It's been a high-level issue for years at this point, both nationally and through all the states. This one, sadly, is not yet scheduled for a hearing, but we hope that changes. The goal is to secure a hearing. And in fact, MSDC sent a letter to the Committee on Health, and that was signed by over 120 physicians, hopefully many of you, and healthcare professionals representing 21 different zip codes in the district, asking for a hearing on this because it's so important. So we'll talk about that in a little bit as well. So what we're going to be talking about with these this evening is for the Copay Accumulator, how to give good testimony on that and what to highlight. And for prior authorization, we'll be emphasizing how to kind of communicate with the council and your respective council members in order to try to secure a hearing. So for those who aren't aware, just a little bit of background about what the Copay Accumulator bill is. So in brief, health insurance companies and pharmacy benefit managers have created these so-called Copay Accumulator adjustment programs, which in essence excludes the value of any discount provided by a third party from counting towards the insured's deductible or out-of-pocket maximum. So in other words, let's say that someone needs needed adalimumab or Humira for psoriasis in my world of dermatology, and where obviously high pays are incredibly common. And let's just say that AbbVie, the manufacturer of that drug, covered most of the copay, the patient is likely to go with that drug because it's covered, right? But that discount doesn't last long. There's usually a sell-by date on it, and the insurer may exhaust that, or the insured may exhaust that manufacturer discount and then end up paying all of the out-of-pocket costs under their cost-sharing agreement. So in essence, the insurance company gets a double benefit and they're effectively overpaid. One, they receive the value of the manufacturer's discount, and two, they receive the insured's out-of-pocket payment. So in essence, what was designed as a way to cut costs for the insured actually results in higher costs for consumers, which are our patients, and lower costs for the insurers. So basically, the bill requires that any discount, coupon, or other third-party assistance be applied to the insured's copay or deductible or out-of-pocket maximum as if the insured had made that payment, okay? And one important other piece of background on this is that CMS finalized a rule in July of 2020 allowing commercial insurers to use copay accumulators, even if a brand name drug has no generic equivalent or appropriate alternative. There's no requirement for transparency from insurers or PBMs about these programs, and it often results in a big surprise for the patient. And, as I said before, many manufacturer copay assistance programs may fund a treatment for only 1 year or a finite period of time. And after that assistance runs out, patients cannot afford to pay for that prescription anymore because they still have that out of pocket to reach. And patients often don't know about those policies until the coupons are no longer usable, and that may result in them completely stopping the drug. And so there is legislation kind of pending and kind of wafting its way through the federal system and the House specifically. But what we're talking about is the copay accumulator bill that's in DC Council right now, so we can get this done on a local level. And so the bill language is listed right here. I won't read it verbatim, but this is where you can see the actual language on the bill, and there is a link to that bill at the bottom of the slide where you can see it on the DC Council website. And just to kind of drive this home a little bit more, 14 states and Puerto Rico have all passed bills to ban copay accumulator programs. And this is an excerpt from some of the rheumatology advocacy web resources, basically showing in a great infographic how this issue is of particular importance for vulnerable and otherwise disadvantaged patients, and it results in shifting costs to some of the sickest patients. So it is a huge exploited loophole that really needs to be closed. And fortunately, this is going to be up for a hearing on Monday. And so to talk about that, so this will be the Committee on Health, the public hearing, and there is a website listed at the top of the slide that you can go to for more information about this. I believe that this is one of 4 bills that are going to be discussed at that hearing, and it will start at 10 a.m. It will be a remote hearing via WebEx, and it will be streamed live at the address you see there. So testimony can be delivered to this in one of 2 ways. It can be oral testimony during the hearing, or it can be written testimony. And if you're interested in providing oral testimony, and first of all, we're more than happy to help anyone who's willing to testify or wants to testify with this. But just some information there in case you want to do it on your own. What you would do is you would contact Malcolm Cameron, who's the legislative analyst for the Committee on Health, and the email address and phone number is listed there. And you would want to reach out by 5:30 p.m. on June 23rd, which would be this Thursday. And what you'll want to do is provide your full name, the name of the organization you're representing, your email address, phone number, and the specific bills that you'll be testifying about.
And I just want to make sure to stop in right there for a second, only just to say that if you work for a like me for Children's National, you have to make sure you get approval from your organization to actually put your name of the organization you're representing on there. So I don't want you guys to get in trouble by saying something like that.
Yes, and that's a great point. And you can also speak on behalf of yourself. You don't have to speak on behalf of an organization. If there's any problems there, you can't get that approval, right? Which is a really important point. But anyone can also testify as an individual as well. The testimony for the oral hearing will be limited to 3 minutes. At least that's the case as of now. But you can also submit testimony in written fashion. And you would email to that same address. You get a little bit more time for this before 6 p.m. on Monday, July 11th. And you would just want to be sure that you reference that hearing in the subject line. So 2 different ways to go about that. And again, this presentation and the slides will be available afterward in case you need these links or all that information after the fact. Okay, so that would be for the hearing on Monday, at which point the Copay Accumulator bill is going to be heard and discussed. Now, we also wanted to talk about the prior authorization bill. This is B24-655, the Prior Authorization Reform Amendment Act of 2022. And as I mentioned earlier, this one isn't so far up for a hearing, but we want it to be, right? And this one is one in which we're gonna talk about it, but the main ask of everyone this evening is to reach out to your council members to basically request that this go to a hearing. So what this bill does, it's a set of common sense reforms that have been already adopted by numerous states regarding prior authorizations. It would require, and we'll talk about some of the requirements in more detail, but it would require a medical reason for a prior authorization. It would mandate that appropriate medical professionals perform the utilization reviews and not just someone who has no experience with that topic. And it would also require a standard time for insurers to honor issued prior authorizations. This has all been modeled after American Medical Association model language, reviewed by MSDC, of course, and other medical associations. And as we alluded to earlier, it would be one of the highest impact bills for the House of Medicine in years. We know that prior authorization has a lot of impact on patients and us, frankly. The website to the legislation language is listed at the top here. And just to kind of, refresh, we know that prior authorizations delay treatment. We know that one of the issues is that there's no transparency on the insurer end about what, the criteria are for the PAs and who processes them, what information they're using. Decisions are, of course, made based on just numbers, crunching demographic data, not based on the most critical person in the room, which would be the patient who needs that critical treatment. And many of you are probably already familiar with this information from the AMA's 2021 National Physician Survey. More than 90% of physicians reported care delays because of prior authorizations. More than 80% reported that prior auth can lead to total treatment abandonment. 35% reported that prior auth has led to a serious adverse event. Physicians and their staff spend an average of 13 hours a week on prior authorizations, and physicians complete an average of 41 prior authorizations a week. And 40% of physicians have staff who work exclusively on prior authorizations. And all those are, talking points that you can use in any sort of testimony. But again, just to talk a little bit more about the granularity of what this bill will do. So it lays out a minimum length that a prior authorization is considered valid. It sets qualifications for payer personnel to make those determinations. And it prohibits review based on cost only and only allows it for medical reasons. And it requires that utilization review honor a previous prior authorization for the first 60 days of coverage, and requires payers to make prior authorization statistics publicly available to help with this whole transparency issue that we have. So the action items here would be, again, this is not up for a hearing on Monday. That would be the Copay Accumulator bill. But for the prior authorization bill, we want you to help us ask your council members to support the bill once it leaves the committee. And most importantly, at this moment in time, if your council member happens to be on the Committee on Health, and all those names are listed below, as I mentioned earlier, ask them to push for a hearing. So if you live in wards 1, 6, or 3, and also Ward 7 for Vincent Gray, definitely let them know that we need a hearing on this issue. And some additional resources here. So MSDC has put together fantastic resources on prior auth, and there is a full kind of set of online resources on their prior auth reform page, including a document with a full slate of talking points. It includes downloadable draft language that can be sent to council members or given orally to council members, and also a downloadable patient brochure for your office. This is an example of what some DC physicians are saying about prior auth, and to the point that we've been making about the importance of the patient's story and the emotional connection to all of this. So talking about denied access to contraception, the impact on medical student training, where it takes time away from their training on issues more salient to medicine when they have to be dealing with prior auth. And the list goes on in terms of access and coverage and all of these issues that actually impact the care that patients are able to get. This is an example of the draft email language that you can find on the MSDC site that goes over, you can fill in with your own personal information. You can add to it, take out. This is just a template that you can use to help guide you in those communications with your council members, and we encourage you to use this. And then finally, I just wanted to show an example of the patient brochure for your offices or any other public-facing patient resources for which you might be able to use this. And this is also available on the MSDC website as well, just so that our patients can be more familiar with this issue and can advocate even in their own spaces, because we do know that the patient voice is incredibly important to the council members and to the advocacy process as well. I would be remiss if I didn't also mention that the AMA has done incredible work on this issue. There's a dedicated website, fixpriorauth.org, and this goes over a huge repository of resources, including model legislation, the experiences in other states, as well as kind of a state-by-state overview of how this is playing out nationally. So feel free to reference that as well for more information and ideas about formulating patient stories. And so those really are the main points that we wanted to get across in terms of our high priority items. So just keep in mind that, we encourage you to testify and participate for the hearing on Monday in terms of the Copay Accumulator bill. And then, of course, for prior auth, reaching out to council members to request that this go to a hearing and make sure that they know that we support that bill. But at this point, I'll turn it over to Dr. Schott to see if she has any other final comments from her perspective, and then we will open it up for questions, comments, feedback, and anything else that anybody wants to talk about.
Yeah, one of my thoughts is just not to forget to do some of the written kind of things from advocacy standpoint, like social media or even or the letter writing can be very impactful too. Even though, when he was talking about the letters, and those are great, and they will keep tally of how many people they are getting from these letters, but it's really important, actually, especially if you're doing it on a federal level from a letter perspective, to change the title and change something in the body of the text, because what they do is they kind of group them all together, and it looks like only one type of one person's release. And that's not one person. They just say, oh, this one person got like 1,500 whatever. But if you change it, it looks like there's even more things coming in to support it. So just adding your own touch and flair to it will take an extra couple minutes, but it can actually be more impactful, especially on a federal and national level.
I completely agree. And also, in Pia, if you're still on, you may have to remind me. Megan mentioned an important point about social media and kind of amplifying our message there. MSDC obviously has a Twitter account, and they're constantly tweeting out great snippets, articles, calls to action. And there is a specific hashtag that we're using with prior auth, and I believe it's hashtag fix DC prior auth, if I'm not mistaken, Pia.
Yes.
Perfect, good. So, so if you want to tweet anything out to the world or to the council, or just kind of mentioning MSDC, that's another way of getting this information out, since everything seems to be moving towards social media these days. So yet another way to kind of amplify that message. And do we have any questions from anyone at this point? Obviously, keeping in mind that you can reach out to us offline, or and again, you'll be able to access all of this after the fact as well. And also, while we're kind of waiting, and Dr. Schott, you may be able to speak a little bit to this as well. So, you know, not only do we have all of the resources of MSDC and our own institutions, but, you know, we also have a lot of work that our individual specialty societies do. And there's a lot of advocacy that comes from those domains as well. And so I think, you know, just important that we're all, you know, working together, you know, a unified front on this. You know, prior auth is one of the great unifiers for so many of our specialties, just because who doesn't deal with prior auth? And so, you know, there's, I'm sure, resources within your specialty societies that you can bring to MSDC in terms of other folks' perspectives and different things like that. So that's another dimension of this that's important.
Absolutely. And like some of the stuff through, at least from the psychiatry end too, is they actually will sometimes they'll pay for a family to come to DC to speak on a federal level. So it's not just, I mean, they assume, I guess, physicians can afford it, I don't know, but they will actually pay for a family to actually be an advocate, especially if that's the case. And so like you, like knowing who your family is and who's would be a good talking point, I guess, on that level will be very helpful as well.
I agree. And for any of you that happen to be clinician educators or have relationships to medical schools, residency training programs, you know, advocacy is such a great way to get students and residents involved. You know, I think, you know, it's important that we, you know, kind of lead by example and show that, you know, our profession doesn't just exist in a vacuum, and it doesn't just end where the clinic door ends. You know, we are subject to a lot of pressures from the legislative spectrum, the judicial spectrum, as we're seeing. And I think it's a great way to get students engaged and passionate and active, and to realize how meaningful this work is, and that their expertise is going to be valued and appreciated, you know, by not only their patients, but by the politicians who rely on them to bring forward that advice and critical insight and expertise. So definitely something to think about for any of you that cross paths with trainees.